Good afternoon, financial professionals. My name is Jennifer Nadeau, Case Design Specialist here at LIBRA Insurance Services, welcoming you to the BREW, Building Relationships Every Week. For those of you tuning in for the first time today, we like to start off the BREWcast by celebrating what today's National Day is. And today, we've got a couple good ones for you. It is National Button Day. Not sure how we celebrate that one, but it's National Button Day. It's also National Fast Food Day, National Indiana Day. And as with every day in November, because November is Long-Term Care Awareness Month, we're going to call this Long-Term Care Day as well. On today's BREW, we welcome LIBRA Insurance Partners Medical Director, Dr. Frank. As we continue to focus on November's Long-Term Care Awareness Month, Dr. Frank will discuss his role as a medical director. We'll talk about long-term care and also other relevant topics within underwriting in the industry in general. As always, feel free to use the chat box to share your thoughts or ask questions. And all attendees are in a drawing for a prize, and we will announce the winner at the end of the call. Thank you for tuning in today. And Dr. Frank, good afternoon. We're very pleased to have you on the BREW today. Thanks for joining us.
Well, good afternoon. Pleasure to be here.
Wonderful. So as we get into our questions and the topics today, you're medical director for LIBRA Insurance and Services, and there are some folks that may not know exactly what a medical director is or what a medical director does. So I thought it would be great to kind of give us a level set as far as what exactly that is. So thank you again, Dr. Frank.
Sure. Companies are required to have a medical director, or life insurance companies and health insurance companies. I'm not certain exactly how that works, but it is a legal requirement. And I think it's because they're making medical decisions. And so medical decisions can't be made by somebody who doesn't have a medical license. That can be an MD or a DO, but pretty much every company in every state is required to do that. Many companies just have part-time medical directors, and they may even be doing remote work. They may not even be in the office or anything like that. But most of the larger companies will have at least one full-time medical director, and many of them have 3 or 4 full-time medical directors. In the old days, everybody was working in the office, but nowadays, there's a lot of them are working remote.
Right.
And the idea of a medical director is to assist the underwriters and provide them with additional medical information in cases where there needs to be discussion about, what's going on. Medical or underwriters, obviously, if they're new, they have limited experience, limited medical knowledge. Ones have been around for many, many years, probably almost as smart as some medical directors. But there's always cases where the underwriter will go to the manual and there'll be a recommendation about to do this or do that. And then sometimes in difficult cases, even the underwriting manual will say, refer to medical director. And those are cases where you need, it's a more complex case. There needs to be somebody with more advanced medical knowledge to try and make a decision about, whether this case is insurable or how rateable, et cetera. Mm-hmm. Most medical directors do take specialized training in that. There is an organization called the American Academy of Insurance Medicine, which is one of the specialty boards recognized by the American Medical Association. And most medical directors, we take additional training. We take examinations and get board certified in insurance medicine. The other interesting thing about, and I found this personally kind of a problem sometimes, medical directors will come from all walks of life, okay? I had a good friend that was a psychiatrist that became a medical director. Now, he was a smart man and became a good medical director. But when he started out, he was a psychiatrist. So he didn't know anything about treating diabetes, about reading EKGs, et cetera, et cetera. So there was a large learning curve, for him too. Most medical directors that have been in general practice or internal medicine like myself, we kind of have a heads up, a start on that. But anyway, so what the medical director does is take his additional training, his medical knowledge, and helps underwriters understand cases, especially in complex cases, to come, to arrive at a decision. In most companies, interestingly, the medical director is not the ultimate person that makes a decision, though. You think they would be, but they're still just a consultant, okay? So the underwriter may come to them, or the chief underwriter usually is the chief. That's the person that really makes the final call. They'll come to the medical director and say, what do you think about this case? What's your input? And they'll talk about it. The medical director might say, I want to do this, but there's other things that are, part of all the cases too. Who's the agent on the case? How important is this case to that agent, et cetera? So sometimes they have the ultimate decision about what to do with it. But most of the time, the medical directors can twist their arms and say, listen, this is what you have to do from the scientific medical standpoint in terms of rating, declining, or et cetera. So to me, they're an extremely important part of the underwriting process. The other thing I'll say very quickly is, I don't think often enough the medical directors are connected to the case correctly. Underwriters will look at a manual and they'll say, okay, this is a table B. But it's something they don't really understand, but they don't know they don't understand. So they'll throw that offer out there, and then it's only, in the back door when the agent then says, well, you quoted me standard on this, before, why are you giving me table B?
Right.
And then they'll take it to the medical director, and he'll say, well, you missed this, you missed that, and yeah, it should be, rated better or something like that too. So when, of course, I am retired now, I was in the industry for over 20 years as a medical director, but I would encourage my underwriters to come to me all the time, and that's what I'm there for. And the more I could be involved, I think the better the decisions could be made. That might be harder to do now in the world where everybody is working remote too. Again, in my day, we were all sitting in this big room.
Right. You just go down the hall. Yeah.
Hallway and talk to everybody, and they can come down and talk to me.
Right.
When it's remote, that's more difficult to do.
Right.
But I think all agents need to understand that when you start to push back, the first thing you push back on is you say to the underwriter, was this case seen by the medical director? Okay. And if they say it was, well, if they say it wasn't, then that's the first thing you say. Well, take this information, what I'm telling you, and take it to the medical director because he may have a different insight into this than you.
That's very helpful to know. I've been in the industry for a while too, and it's helpful to hear too that the medical director, you and your colleagues aren't the final say. It is the chief underwriter. That is the line in the sand. This is it. But it was also helpful to hear from you as you just closed up those comments with, if you have a case that you are pushing back on, or you need some additional insight, or you don't agree with, asking if it's been seen by a medical director. Sometimes we just need those words to say.
Right.
So thank you very much for that. That was extremely helpful. Let's transition now into, it's November, Long-Term Care Awareness Month. I know you and I had discussed just some general observations that you have and general comments about the LTC industry. So if we could just move over and transition into long-term care and just your general comments there, Dr. Frank, would be great. Sure.
I think long-term care is something that in the past, companies didn't pay a whole lot of attention to. It was just kind of a nice, add-on, et cetera. I think in general, companies take a conservative approach to long-term care. I know at both the companies I worked at, if you were rated table 4 or higher, you automatically did not qualify long-term care. It doesn't make a difference what your condition was. They thought, if we're going to rate you a table 4 and up, you don't get long-term care. Plus, there's many other conditions, obviously, that have no impact on mortality whatsoever, but have a huge impact on whether or not you get long-term care. So a company can have a huge list of, problems with their back. Let's say they've had several neck surgeries and back surgeries, and they're, terribly almost incapacitated from their spine. It's not going to affect how long they're going to live, but it sure will affect in terms of the long-term care. So I think overall it's conservative. And it's been my impression too, that when you try to push back on long-term care because they are conservative, it's hard to get them to change their mind,
Mhm.
But there are times again too, when you have to look for the good things in all the cases to push forward, with them. But yeah, that's about it. They're
Yeah.
conservative, and it's going to be harder to sometimes get long-term care cases reconsidered, et cetera, than it is even the life cases.
Right. And part of that might be too, and I'm just sharing my own thoughts or opinions, is that many times with long-term care, it's just pass or fail, basically. There aren't
Right, right.
these table ratings or,
That's correct. That's correct. Yeah,
notches.
it's
Yeah.
yes or no.
Yeah.
Yeah.
And it was good too. Again, you mentioned table D or table 4 or better. And I was always troubled by that, with just someone applying for straight life gets a table 5, we'll say, is disqualified for long-term care. But I was always just troubled by, well, wasn't that underwritten for mortality and not morbidity? So that was very interesting, interesting as well. Could you talk a little bit about COVID, and especially long-term COVID, as we're coming out of the pandemic? I'm not sure, but just long-term COVID, I'm hearing a lot about that, and how it affects the industry in general.
Well, that's interesting you brought that up, because we had talked about that. We were talking about long-term care, and I mentioned that I think this concept of long COVID is going to have some long-term care implications. And it very interestingly, just last month in the JAMA, the Journal of the American Medical Association, there was a big article where they had studied for the last couple of years in 2021 and 2022, over 1 million people who had COVID, and how many of them, developed the so-called long-term COVID. And I'm just going to throw some stuff out there. There were 3 general categories of these people with long COVID. Cognitive issues was one, and it was found in about 2.2% of people who had COVID. Fatigue, aches, not just feeling well in general, kind of almost like a chronic fatigue syndrome type of thing, was present in 3.2% of people that had COVID. And then pulmonary issues with persistent cough and shortness of breath was present in about 3.7%. So you can see these are low percentage of people with long-term COVID, but you add them up, 3 and 2 is 5, 3, you're talking about 9% of people then had some kind of long-term COVID issues. Now, the good news is most of these issues resolved within 6 to 9 months. And very few people, there was a very small percentage, in fact, it was less than 1% of these people had symptoms that persisted more than 1 year afterwards, which is good news from the standpoint if you're the person with it too. But and back up about long-term care, I think that carriers, and I have not seen any cases like this, but I'm certain if a person was diagnosed with COVID, 6 or 9 months ago, and you're applying for long-term care, the carrier is going to want to know this person has made a full recovery, or if they're one of those few people that are suffering from long-term care or issues.
Right.
Because obviously, if they have cognitive issues, if they have that fatigue and aches type of thing, which is like the chronic fatigue syndrome, or if they're having pulmonary issues, those people could be at increased risk then for long-term care. So if anybody has anything like that, I'm certain they're going to postpone that person just flat out. And I don't know any way you'll get them to change their mind. But the good news is that person should make a recovery. So maybe later on down the line, if they're declined now, 6 months from now, if they made a full recovery, you should be able maybe to go back and get it reinstated or, something else or added on or whatever like that.
Mhm.
But yeah, long-term COVID is going to be an issue in terms of long-term care, I think, in the next, 6, 12, 18 months as people are recovering from this epidemic.
Sure. I have a follow-up question to that as you were speaking. Do you foresee carriers or just the industry in general caring or asking about the vaccine or boosters or having that matter when it comes to underwriting and that sort of thing and qualification?
I don't think they will. I think we're going to end up with COVID somewhere like the flu.
Yeah.
It's going to be kind of an endemic thing. It's going to be around. People die from the flu. People are going to die from COVID. But I think that once the majority of people, and the majority of people are already immunized, at least with one shot and stuff or two, the mortality from it is going to drop down. So I don't see any companies are going to be taking any kind of adverse action because a person was not immunized, but I also don't see them giving them any kind of credits if they are immunized.
Okay.
Probably
Yeah.
no.
Yeah. Thank you
and
for that.
That's, as long as things keep heading in the same direction, they're heading.
Right.
A crazy variant would come along and all of a sudden things would flare back up. It would be a different story, but I don't think there'll be too much problems there.
Okay. Yeah. Thank you for that. One more question before we open it up to the group. Again, when you and I were talking before, we were talking about underwriting and ECGs or EKGs in particular, and we're going to get specific now in underwriting, but some challenges with underwriters' interpretations of ECGs or EKGs. And again, you touched on it in the beginning, just about training and that sort of thing. But what are some of your thoughts or comments there surrounding just challenges that is faced in underwriting by reading some of this stuff, for lack of a better word, without being an MD or a doctor?
Good question. And this, by far, the number one issue that I see in cases that are sent to me and say, will you please look at this? We got an adverse offer, et cetera. It has to do with echocardiograms. Echocardiograms are complex. They're very commonly done in people. Doctors are doing them all the time. And the underwriters just don't have the training or experience to understand what that echocardiogram means. And more often than not, they look at this echo report, the interpretation from the doctor, and it'll look bad to them.
Right.
But it's really not bad, but they don't know any better. And so they'll, decline or rate this person or postpone this person. And that's the number one question that I get, okay? And this goes back to about the medical director, because all those cases, I think, need to be pushed up to their medical director, because the medical director should have a lot more knowledge and experience with looking at echoes. There are many medical directors that are still lacking, in my opinion, how much they should know about echoes. But that's the number one condition. So if you ever have a case where an adverse decision was made because of an echo, don't be afraid to toss that my way, because there's probably a pretty good chance, okay, that after I look at the echo and make some comments and kind of reinterpret this thing in the correct way, we can go back to the carrier and say, listen, here's the information, here's what the echo really says. Would you please take this to your medical director, let him look at it, and we can get things changed. And I will say this one, on the echoes, one of the biggest mistakes that's made is the interpretation or reading what's called the pulmonary artery pressure. It's a complicated formula that's fraught with errors. the cardiologist will give you a number. They'll say 35 or 40 or 45 or whatever. It's a number that really has no clinical meaning. But when the underwriter looks at that, they'll go to their manual, and the manual will say postpone or decline. Okay. And this happens so often that I actually wrote a form letter, and it's on the LIBRA website. So if you have a case where adverse action was taken because of a pulmonary artery pressure abnormality, so-called abnormality in the echo, you can take that form letter, fill it in kind of, with the person's name, et cetera, and send that off to the carrier and say, would you please have the medical director relook at this in light of this information that I'm sending you. We had that so much that I thought we got to write a letter about that.
Wonderful.
So,
yeah.
So that's on the LIBRA website there.
Excellent.
But yeah, echoes, the number one reason I see cases, and it's also probably the number one way we can kind of get things changed too. If somebody is rated for coronary artery disease, sometimes you have no thing to do to get them to change their table 4 rating, let's say. But echoes are really complicated, and there's a lot of nuances, and we can get a lot of times things changed. EKGs are kind of the same, but they're less likely to make mistakes on EKGs than they are echoes.
Understood. My lack of medical knowledge. ECGs, EKGs, very different. All right. Thank you for that, Dr.
You're
Frank.
welcome.
I think that certainly my takeaway is do not be shy about asking for something to be looked at by the medical director, because it absolutely can make a difference. So really appreciate that.
Right.
If you don't mind, I think it would be a good time to open it up for questions now.
Sure.
While we're waiting to see if there's any final questions, I'd like to remind everyone that today's brew and our full library are recorded and shared on the BREW blog on our website at www.e4.insurance. We also do our giveaway. Dr. Frank, I would like to ask you to pick a number between 1 and 20, and that will be our winner of the giveaway today.
Number 16.
Number 16. Oh, Abby, congratulations. Be on the lookout for a complimentary CE voucher and Starbucks gift card that will be coming your way from all of us here at E4 Insurance Services. I am going to take a peek in the chat box here. You can also unmute your lines if there's any questions. And I'm not seeing any in the chat box. Again, Dr. Frank, we certainly thank you very much for taking the time to spend with us today on the brew. Very, very helpful, great information.
Okay, my pleasure. It's nice talking to everybody, and hopefully we make things easier to get cases placed in the future. That's what it's all about. Absolutely.
Thank you again. Tune in next Wednesday as E4 Insurance Services welcomes Jay Spence, Training Manager at National Western Life Insurance Company. Jay will share with attendees competitive solutions that advisors are successfully using now to help clients in this turbulent economic environment. Have a great week, everyone. Thank you for joining, and we will see you again next week on The Brew. Thank you.